our past. So welcome to the 1000th Zoom meeting of your life. Because I think all of us probably are living in Zoom. We're exhausted. And for those of you who don't have your screens on, I hope you're in your pajamas and you're relaxing. For those of you who do have your screens on, thank you for showing us that you're alive and well. And we welcome you to another in our series of racial justice conversations. In the wake of the George Floyd murder, our law school, like many other institutions, decided that we had to do a number of things and take our game up several levels with regard to social and equal justice. The very mission of our law school, Cleveland Marshall College of Law at Cleveland State University, is learn law, live justice. So unlike many organizations in the world, our mission has always been social and equal justice. But that doesn't mean that we can simply rest on our laurels. In fact, it's quite the opposite. We recognize that we have a special responsibility to take our game up many more levels. As a result, we put together a call of action. We created a racial justice task force. We have four very active racial justice work groups consisting of alumni, faculty, staff, and students who are working every single week to make sure that we do a better job at our school climate, to do a better job at training and education, to do a better job with regard to effective public action on the legislative and policy level. And we have a work group that is focused on community conversations like this one. We have had many of them. I haven't counted, but I wouldn't be surprised if since March, we're probably over 50 of these kinds of panel discussions that we've had. And I'm still amazed at how many people still show up after having done all these. Today's may actually be, however, the single most important and relevant, because we are right now living through an unprecedented pandemic. The last time I looked, if you look at the worldwide statistics, 52 million cases of COVID-19, 1.2 million deaths. In the United States, it's 10 million cases and about 240,000 deaths. It's unprecedented. And as we've seen recently, it's not getting better, it's actually getting worse. And to make that even more serious, it's compounded by the fact that there's a disproportionate impact on minority populations. We've always had health disparities, we've always had health inequities, but they are never more severe than they are right now. And so we're very lucky to have three experts today on this subject, each who can give us a different perspective on this very important issue. What's going to happen today is I'm going to introduce each of them. Each of them is going to make some opening remarks for about 5 or 10 minutes. And then I'm going to ask them some questions, but we're also going to open this up today to all of you. And in the meantime, if you have a question, you can always put it in the chat function. I probably will still call on you unless you don't want me to and ask you to state your question verbally. But that way you can at least have it in the parking lot in our chat function. And we'll do that probably about a half hour into our discussion. We'll be doing this for at least an hour. Sometimes we go over and go maybe an hour and 15 minutes. I ask all of you to keep yourselves on mute while each of our panelists give their opening remarks. Our three panelists are Professor Gwen Majette, right here at the College of Law, who is our health law professor. We have Dr. Charles Modlin, who is the kidney transplant surgeon and urologist at the Cleveland Clinic, and Professor Colleen Walsh at the CSU School of Health Sciences. Now, let me give you a little bit more detail about each one. First, Professor Gwen Majette. Professor Majette's scholarship centers on healthcare law. Her work focuses on patient rights, delivery system reform, global health, and healthcare reform, including, of course, the Affordable Care Act. Her work has been relied on by the United States Commission for Civil Rights, the Department of Health and Human Services, and the World Health Organization, and she's cited in one of the leading health law texts. Dr. Charles Modlin, who you can't miss because he's the only person on the call that I see with a white coat on, is a doctor at the famed Cleveland Clinic. He's a kidney transplant surgeon and urologist. He's the founder of the Cleveland Clinic's Minority Men's Health Center and the annual Minority Men's Health Fair. He is world renowned, and we can't wait to hear what he has to say about what's going on in his practice at the Cleveland Clinic. And last but not least, we have Professor Colleen Walsh. and our health and sciences school here at Cleveland State University. She's a medical anthropologist. If you don't know what that means, you're about to find out because she'll explain it. She's focused on urban health. She's interested in using anthropological, I can't say it, but you know what I mean, and political economic models to understand urban living and health inequities. We're going to start today with Professor Walsh, who was going to give us her perspective and a little data. So Professor Walsh, it's all yours.
Oh, thank you so much. I couldn't be more honored and humbled to be here and be on this panel because it's really amazing opportunity. So yes, a medical anthropologist, the easy way of saying it is that we study health and illness from a cross-cultural perspective, but we also ground it in evolutionary perspectives. And when I say I was specifically trained in, so you can be a biological anthropologist or a cultural anthropologist or an archaeologist or a linguist. We kind of tend to all get training on all of those. I focus much more in the cultural realm, though I take all the other subdisciplines or the branches of our field into account. So thinking about the way that we didn't evolve under urban conditions and what does that mean for our health and our health outcomes. So the environment, physically, but also politically, economically, socially, all these things. So my research really takes an ethnographic approach. So ethnography is really living and talking with people and trying to experience life from the inside out, from thinking about it. So a lot of the things that we do is trying to understand problems, especially in medical anthropology, health problems from the perspective of people experiencing them to find better solutions that are culturally relevant and acceptable and feasible. And so when you think about it globally, I might learn something about how to address a disparity here in Cleveland by looking at something that happened in a study in Sri Lanka or something. So thinking about it in those terms. But today, I guess I can share a few data points in thinking about some of the projects that we've been working on without going too far over. I have a gazillion slides, but I'm not to show them all, but here I'm going to share this screen. Okay. Wait, why isn't this letting me? Oh, hold on.
Take your time.
There we go. It's letting me know. Okay.
Good. We see it.
Can you see this? Okay. So thinking about, I'll tell you a little bit just about our the importance of thinking about the lived experience of race is really thinking about what people tell me when I sit down with them as an anthropologist, to have a conversation in the context of someplace safe and comfortable, and thinking about what it is to have the lived experience of race from all perspectives. These are just 3 examples of quotes from, they happen to all be African American, but thinking about what it means to be Black in the United States. The first man is talking about having to carry the whole race, that we don't look at Black folks in this country as individuals. He was expressing this dismay of, why can't I just be the salesman job? Why is the whole race got to depend on what I do as an individual? And that's something that we as white folks, we take that for granted, that we get to be looked at as individuals in this country. So having this conversation helps you think about, what does that mean, that burden, that chronic stress that we talk about living in the health implications of chronic stress. Or just thinking about the second woman talking about very vividly, remember being called the first time she was called the N-word, and how differently she was treated in her Catholic school growing up compared to the white women in her class. And then another decision maker in our region who just said, I don't know, it's part of our DNA in this country, honestly, to just, that it is what it is kind of a thing. And it's not to be dismayed, but it's thinking about the way when I sit down and have conversations with people, how they think about health. No, I always forget this doesn't like that when you do that. So we talk about this, and we just to go over, I'm happy to talk about a lot of our findings that we have, but thinking about that interpersonal racism has an impact on health, the way that you are treated as an individual, discriminatory, cultural racism, who do we value, who do we hold up and lift up as good, quote unquote, or bad in our cultures, and how deep does that go? But then a lot of the work, and I'm sure a lot of the conversations you've had in these forums are about those structural and institutional racism. So in my work, it's trying to think about unpacking that, knowing that individuals are making those decisions, and that individuals' values matter in terms of policy. So so we as anthropologists in this study were thinking a lot about how we look at individual values and how those change over time. So I'm happy to talk more about these things. I'm sure you've seen the redlining maps and life expectancy, but without going into those things, I'll tell you more about ARCHES as the study if you want, if we have time to discuss more the actual, some of the data points from this, but just thinking generally about how we look at health and how it matters in terms of people's own lived experience of that. So I'm gonna stop sharing, stop share, there, does that work? And then we can go back to that if we have time, some of those slides.
Professor Walsh, thank you. Let's go next to Professor Gwen Majette, who's going to be talking about discrimination and unequal treatment and access to healthcare. Professor? Right now you're, okay, there you go, you're off mute.
Hold on 1 second.
I think we're just waiting for you to share a PowerPoint, am I right?
Yes,
Okay.
I had to bring it up first. All right. Amy told us that we had 10 minutes, and I actually am taking 14 to present an article that is, I was going to say forthcoming, but I actually got the article from the journal yesterday. So this is an article that is published in the Georgetown Journal of Law and Modern Critical Race Perspectives. So I wanted to talk about this piece because it gives you an overview in the context of efforts that have been taken in the United States to reduce healthcare disparities over time. So this piece grew out of an invitation to a conference that was thinking about the progress of the status of people of color in the United States. And people took different angles looking at that. And I decided, because my scholarship had been about healthcare disparities, to continue to think about that theme. All right, and so the title of this piece is based upon the last speech that Dr. King gave before his death. And so this piece is building upon some ideas that he shared with several types of leaders in his last speech. In his last speech, he was focusing in on economics. And he spoke to the clergy at the time. He said that they should have relevant ministries. He spoke to government officials. He told them that they should end laws that oppress people of color. And then he spoke to the business community. And he told them that they should treat people of color fairly in their hiring. So when we start to think about the health of people of color in the United States, it's very important to think about the fact that their health is shaped out of the circumstances. And that's kind of the idea that Professor Walsh was trying to tell you. We call this ideas social determinants of health. And at the time, going back to pre-1964 and the Civil Rights Act, people of color were discriminated against in receiving their health care. There were separate hospitals. The physicians that they had to go to were separate. The quality of care provided to people of color was horrible, putting it mildly. And millions of people died. So if we go back and we thinking about Dr. King's life, we think about some major pieces of legislation that change the legal structure to protect people of color. We must start with the Medicare and Medicaid Act that were passed in 1964. Medicare is the legislation that focuses in on financing for elderly people, Medicaid for people, poor people. And the Civil Rights Act, Title VI, specifically focuses in on entities that receive federal financing, and this targets healthcare facilities. Now, I'm sharing this for this purpose. Medicare became very important for desegregating healthcare in the United States because Title VI, when it was enacted, it was not being enforced. But President Johnson decided that the hospitals and the providers in the South were going to have to desegregate in order to sign up for Medicare. And this facilitated desegregation for our healthcare system, very important. The next piece, and those were in existence when Dr. King was alive. The next policy to think about is a report, this is in 1985, where the Department of Health and Human Services for the first time recognizes that healthcare disparities for people of color are a serious problem. And then this led to, in 1986, the creation of the Office of Minority Health within the Department of Health and Human Services. Additional key pieces and policies to think about is the presidential initiative to eliminate race and ethnic disparities. This is important because this was the first time that a decision was made in the United States to actually focus in on eliminating healthcare disparities in 6 areas. Some of those 6 areas include cancer, diabetes, cardiovascular disease, HIV, infant mortality. And if you think about some of the issues that we're having with COVID and who are the people who are dying, those are some of the areas, those underlying conditions. So you can see the structures from the past moving forward to the present. In 1999, Congress decided to provide funding to the Institute of Medicine. The Institute of Medicine is an academic body comprised of leaders in different areas of science, and they were given money to do a report to study the prevalence and impact of racial and ethnic bias. Now, again, this is important because we don't have information about exactly what is going on. We do have it. People of color were doing research, but it doesn't get the same level of legitimacy. So this report provided funding, and that report came out in 2003. And it was called Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare, 2003. Now, we move forward in time, and the ACA is passed in 2010. And when this piece of legislation was passed, I decided to analyze this legislation very carefully to see what was in it that could be used to improve the health of people of color. And when I did that, I looked at it through the lens of international norms. And when you do that, it helps you see the ACA and in even broader perspective. So issues of ethnic inequity for people of color is not just a domestic issue, it is an international issue. And so I looked at it through what we call the lens of global health law norms. And those are the norms, institutions, and policies designed to create conditions for people throughout the world to improve their physical and mental health. And so in an earlier piece published in the Howard Law Journal in 2012, I argue that global health law norms impose a duty on the United States to eliminate health disparities. And I looked at certain documents. The ones that are binding are the ones that the United States is a member of, or the International Convention on the Elimination of All Forms of Racial Discrimination. That is a treaty that the United States has actually signed and ratified. And that's important to know because that means that there is an international body watching what the United States does. And part of the obligation imposed on the United States is that they have to file reports every 2 years about what they are doing to improve the lives of people of color. That treaty is a broad treaty. It covers criminal laws, it covers housing, but I focus in on health. So I focus in on the parts of the report that deal with that. And then we have what we call aspirational laws. So the International Covenant for Economic, Social, and Cultural Rights, that is the broadest health law treaty. General Comment 14 interprets that. And out of this system, there are reports that are done by the special rapporteur, which are experts that look at and explain what the right to health means. I thought Colleen would talk about this, but I do want to mention this. This is very important. One of the initiatives of the World Health Organization is that they created a commission to look at social determinants of health on a worldwide basis. And they said, here are some things that we need to do with respect to improving people's lives. And these are the ones that focus in on health. Now, so when I look at the ACA through that lens, I make the argument that the United States is obligated to abide by this framework legislation to reduce healthcare disparities. And in doing that, there are 5 key ways that the United States system changes with this framework. First of all, health and health inequity is a priority at the highest level of government. They elevated the office of the Secretary of Minority Health, put that person in the Secretary's office. They created offices of minority health in all of the departments. Health and health sector focuses on health disparities. They're going to take a health and all policies approach. That means that every department, not just Health and Human Services, is going to think about what impact their work has on health. They made universal coverage a priority issue. So that means that we're using exchanges, the insurance market, Medicaid expansion to make sure that people have insurance coverage. And they said we're going to start monitoring social determinants of health. That structure is very important. And in this current piece, what I do is I go back and I analyze and look at that structure to see if all of the things that I thought would improve people of color's health would actually do that. And this piece documents that and shows that. I just want to highlight one piece that's really important, and that is this issue about universal coverage. We have known for a long time that people of color don't have the insurance coverage that they need. It is a problem. The international body has told us this many times. And so when we passed the ACA, they applauded us for doing this because now people of color would have insurance. We had problems, and they highlighted this, when the Supreme Court decided that they were going to let states choose whether to expand Medicaid. It's a problem. That basically meant people in all of the states where they didn't expand, who were below 100% of poverty, did not have access to coverage. So our poorest, most vulnerable people don't have coverage, a problem. So attacks now on the ACA, is specifically with respect to insurance coverage, is going to adversely impact people of color, all groups, primarily Hispanics and African Americans. The other problem with this is that we saw coverage improve significantly for those groups. And you can see the uninsured rate went down significantly. It's not only that we have people getting access to healthcare, but we also see improved health outcomes. They have better financial well-being. They have better psychological well-being. Their infant mortality in the states that expanded Medicaid went down. People who needed to have any type of procedures in the states that had Medicaid, their health was improved, so they didn't have the same level of risk. So this just shows you the importance of the ACA. And I have more to share, but I'm going to stop there because that just kind of gives you an idea of how important this is and some of the attacks and how they're problematic on the ACA. That would be called legal retrenchment.
Okay, thank you, Professor Majette. Next, we're going to go to Dr. Charles Maudlin. For those of you who didn't tune in right at 12, let me tell you that he's a kidney transplant surgeon and urologist at the Cleveland Clinic, and perhaps best known for being the founder of the Cleveland Clinic's Minority Men's Health Center. Dr. Maudlin, it's all yours.
Well, thanks for allowing me to be a part of this. Actually, wonderful presentations. I've learned a lot. Actually, following this event today, I would love to get in contact, with Colleen, Gwendolyn, and others to further this conversation to figure out how we can collaborate to see an end to these healthcare disparities. I've been at the clinic now for about 28 years. As mentioned, I've devoted most of my career to kidney transplantation and urology. Urology is the study and surgical and medical treatment and diagnosis of diseases of the genitourinary tract. And we see and treat both males and females, children as well. But one of my primary interests is in men's health, and especially African-American men's health, because of the greater incidence of healthcare disparities, especially in men of color. And that's why we established our Cleveland Clinic Minority Men's Health Fair, Minority Men's Health Center. It wasn't trying to exclude women or children, but it was to address the disparities in prostate cancer. Prostate cancer is one of the main disease states that urologists diagnose and treat. Prostate cancer, for example, there's twice the incidence and death rate of prostate cancer in Black men compared to white males. And so that's why we started off with a Minority Men's Health Center. I'm going to tell you about some of the work we're doing, and also some of the work that is probably behind the scenes that some individuals may not be aware of what we're doing. I always say it's easier for me to perform surgery than it is to work with this technology. So I'm going to try to share the screen. I'm not exactly, hopefully it'll work. Do you see this? Are you able to see?
We do. You're a technological. Yes.
So I always start out my presentations, and I could speak for about 4 hours, but I'm going to just speak very briefly here. And we want to give people a chance to ask questions. I always acknowledge my parents for the sacrifices they gave so that I might be in a position that I'm in. Also, I want to recognize Dr. King. He said way back, I think it was 1964, 65, in Chicago, our lives begin to end the moment we remain silent about things that matter. And the reason I say this is that elimination of healthcare disparities is something that matters to me, and I want to do whatever I can to eliminate these healthcare disparities. Dr. King, even though he was engaged in a number of activities to promote the civil liberties, civil rights for everybody, he recognized that inequities in health is the most unjust. And so he was well ahead of his time. It seems like with the advent of COVID, we've become more aware in this society about the fact that these healthcare disparities exist. And I think it was Hillary Clinton that said, never let a good crisis go to waste. I don't think I would have actually expressed it that way. But what she meant is that whenever there's a crisis situation, it gives us as a nation an opportunity to address the underlying causes. And it was stated that there's a greater incidence of COVID-19 in Black populations. Studies have shown it's because of the pre-existing chronic health conditions and healthcare disparities in these populations, which is increasing the burden of the COVID-19 pandemic on communities of color. So we can't just address the COVID-19 itself. We have to address the underlying contributing causes. I was proud to serve on the governor's COVID-19 minority strike force, and that was one of the major recommendations we made to the governor, is that as we get past the COVID pandemic, we still have to address these healthcare disparities that are predisposing communities of color to having a greater burden from these pandemics. And so one thing I just wanted to mention, we're all aware of the changing demographics in the United States. Back in 1970, only about 12% of the population was considered to be minority. In the next 10, 15, 20 years, minorities are going to assume the majority population. And I always say it's very important to focus in. Some people say, well, why do you spend so much time focusing in on a minority percentage of the population? Well, pretty soon, this minority percentage of the population is going to be the majority population, who is suffering a greater incidence of and burden of health disparities, lower life expectancies. That's going to have implications on the overall health of the entire nation. So I asked the question, why is the growing diversity in America a crisis? I mentioned that already because of the healthcare disparities that we see. These are some stark examples of some of the healthcare disparities that we see in clinical medicine. Higher incidence of hypertension. We know hypertension, we call it a silent killer. You don't have to have any signs or symptoms. untreated hypertension leads to heart attacks, strokes, peripheral vascular disease, congestive heart failure, can lead to blindness, kidney disease, kidney failure, diabetes, a greater incidence of diabetes in African Americans. We're starting to see a greater incidence of diabetes in our youth also. Higher rates of death from heart disease, kidney disease, 4 to 6 times greater the incidence, 44% greater incidence of death rates in African Americans compared to Caucasian Americans. I mentioned the higher incidence and death rate from prostate cancer. And again, cardiovascular disease, there's also, we're finding as we do more research, there's even a different pathogenesis or underlying pathogenic cause for heart failure, for example. In African Americans, again, a greater incidence, but a lot of it is related to hypertension as opposed to myocardial infarction in Caucasian Americans. So it gets down to the fact that in certain racial and ethnic populations, in certain situations, it can't be a one-size-fits-all approach to diagnosis and treatment, because there's in some situations a different pathogenesis that is contributing to the health disparities that we see. One of the most disturbing things, and we're going to need more study of this, is that we've seen, and there's published literature showing that there's differential screening and treatment recommendations by race, ethnicity, and gender. And it may be related to unintentional implicit biases, may be related to structural racism, lack of access to care. But there was a study that showed when you control for access to healthcare insurance status, blacks were less likely to receive certain recommendations for treating coronary heart disease compared to white Americans. Women especially had differential treatment recommendations, and more study needs to go into that to determine why is it that healthcare providers are looking at individuals and actually coming up with different prescriptions or recommended therapies based on race, ethnicity when you control for access to care. A lot of the, and I'm going to get to, and these are just some other examples, higher incidence of stroke, twice the incidence of stroke, and re-stroke in African Americans, twice the incidence of death, most likely from hypertension, long-term untreated hypertension, higher death rates. I mentioned higher rates of cancer. There is a greater incidence of smoking in African Americans. A lot of the tobacco companies actually target communities of color. Even though African Americans start smoking on average about 3 years later in life, it's more difficult for them to stop smoking. There's less referral to smoking cessation programs. And these are some of the social determinants of health that contribute. Again, the 4 leading causes of cancer are more prevalent in African Americans. One of the things that is promising since we adopted, many healthcare institutions have adopted routine screening for a number of conditions. We're seeing that there are some mortality rates from colorectal cancer, for example, lung cancer, prostate cancer, that are actually on the decline. Yet, however, the disparity still exists between black and white, but it is good that these screenings are actually having a positive effect in terms of declining death rates. And so this is just a diagram showing the overall U.S. life expectancy by race. You can see there's usually about a 6 to 8 year differential life expectancy between white individuals and black individuals in the United States. This data actually isn't limited to Cuyahoga County, but the Department of Health in Cuyahoga County actually has data that shows that this probably doesn't show up too well on the slide, but it shows that if you're a resident of inner city Cleveland, like the Huff neighborhood, as opposed to a more wealthy suburb, Pepper Pike, you can have a 23-year differential life expectancy. And so the title is Where You Live Determines How Long You Live. A lot of that is related to the social determinants of health. Now, the social determinants of health are, and so I have an example slide showing the multifactorial reasons why we're observing a lot of these healthcare disparities. What we feel is that a lot of the healthcare disparities are related to the social determinants of health. Lack of access to healthcare, poverty, lack of education, lower health literacy, where you live, You may live in a toxic environment. You may live in a food desert. You don't have access to fresh fruits, healthy foods, vegetables. You may live in a dangerous neighborhood where you can't go out and walk and exercise. You may live in a house that has lead toxicity, pollution, a number of these environmental factors, along with some behaviors. There's a lot of distrust actually in many minority communities, and rightfully so, based on some of the egregious actions that have occurred at the hands of medical researchers. All these things combine to show the healthcare disparities that we see. There are genetic biologic differences. There's a prostate cancer gene, diabetes, hereditary. So there's a hereditary component, but you combine the hereditary aspects, the social determinants of health, some of the distrust, behavioral factors. Actually, it was recently acknowledged, and again, we've known about this for decades, that racism itself is a social determinant of health. Chronic racism can lead to chronic stress, which can result in higher cortisol levels, which elevates your blood pressure, contributes to congestive heart failure, diabetes. Many other manifestations of physical disease can come from psychological stress over the long term. So it's not enough that we recognize that these healthcare disparities exist. We have to study, determine why they exist, and then we have to come and work together to come up with solutions to address these healthcare disparities. The Ohio Commission on Minority Health is doing remarkable work. I had the pleasure and privilege to sit on that commission for 12 years. Dr. Greg Hall, he works down at, he does some work with the Cleveland State University. He was the chair of the Ohio Commission on Minority Health, so I served under his leadership. And so there are things that we can do together to address these healthcare disparities. One of the things, I mentioned that COVID actually has unmasked the existence of healthcare disparities. I wanted just to highlight, I don't know if you can see this. This is the Margaret Heckler report. You may want to go back and Google that. This is, I think she released this back in 1984, 85. She was the Secretary of Health and Human Services, but she actually spelled out way back in that time to alert the nation about the existence of these healthcare disparities, differential life expectancies. And there's a 241-page report where she actually comes up with all these solutions that we seem to now just be trying to reinvent, but it all, she spells it out, where you have to public education, community outreach, partnerships, work with policymakers. It's all there. I think we need to go back and review a lot of the work that is being done. There was actually a report, again, this is a little bit dated from 2004 in the Public Health Journal, talked about dying for basic care. For Blacks, poor health care access cost 900,000 lives. That was over a 10-year time period. 900,000 Blacks in the 90s died unnecessarily due to lack of equal access to health care. So I'm going to close out by just telling you just very briefly about some of the work that we're doing. So we established our Minority Men's Health Fair 2003. We have our Minority Men's Health Center. Again, year-round programming. We welcome all people to come, regardless of race, ethnicity, or gender. Anything we do, we open up to everybody. But there are some other things that we're doing. We established a Minority Stroke Center in April 2019. We're establishing health equity centers throughout every institute at Cleveland Clinic. In the Cardiovascular Center, we have a lung center, orthopedics, rheumatology, dermatology. So all the different institutes, we're developing all these minority health equity programs, multicultural programs. I call it the Multicultural Health Center of Excellence. And what it is, we have key stakeholder leaders, and we want to provide more culturally sensitive care. We perform a lot of community outreach. I call it community outreach for inReach. One of the things that we have to do, in addition to the outreach and establishing these hands-on care and promoting equal and improved access, improving health literacy, we also have to encourage minority populations to engage and participate in clinical research, because we do know that there are certain medications that are more effective in certain populations. If you drive down Cedar Road behind Cleveland Clinic, about 103rd and Cedar, you're going to see a building going up. This is our Cleveland Clinic biorepository. And that's a collection of freezers. We're going to have about 400 freezers in there that are actually going to be all housed under one roof. And we have biologic material where we're performing genetic research to understand the pathogenesis of disease. We actually have an African-American biorepository that's going to be in there as well. So one of the things is that we need to encourage more participation of minorities in research, but we understand why there's reluctancy in many respects, but the onus is on us to go out and educate the community as to why that's important. So I'm going to stop. And again, it's my pleasure to be part of this panel.
I want to thank all three of you for three excellent presentations. And Professor Walsh, I promise you we'll get back to you because we probably cut yours a little bit too short there. So you're going to get a chance to talk more about your anthropology research. But Dr. Modlin, if you would, thank you. I was going to just ask you to take that away. I want to open it up right now to any questions anybody may have. If you don't have questions, I guarantee you I do, but I feel like I want to make sure that you have a chance to do first. And I see Carolyn's got one. So Carolyn, would you be willing to unmute yourself and ask that verbally?
Carolyn, can you hear me?
Yes, we can hear you, Carolyn. Go ahead.
Okay, perfect. So here's my statement and then followed with a question. Until healthcare systems offer more comprehensive care, I expect diagnostic overshadowing will continue to impact minority and disadvantaged individuals suffering from a combination of medical, mental health, and substance abuse disorders, and those afflicted of all races, but perhaps more so for the African American population because of institutional racism. I believe this is insurance driven, but also more education is needed, as mentioned, regarding multifactorial healthcare disparities mentioned by Dr. Modlin. I'd like to know the panel's thoughts on that.
Okay, well, that was a pretty well thought out question. I'm impressed. Okay, who wants to tackle that first? Professor Walsh, I'm going to give you the first option because you had the shortest presentation today, but you should, and feel free to refer to your anthropology research.
Sure, thank you. I think my first thought about that is that we do tend to focus on that individual level. You have insurance, you don't have insurance, you face bias or discrimination in the healthcare environment, or you didn't. And I think, those kinds of things are only, when we talk about the social determinants of health in the slide that I quickly went over, we know that those kinds of broader things account for much more of our outcomes than do those individual kind of decisions. And so I guess my first thought on that is to think about, of course we need care, and of course access to care and all those things, but we also know that even when we have those, the disparities don't go away. So I guess I'm thinking about it in terms of, you're right, that it's about institutional racism. It's about the way that our systems and structures are designed to be this way. It's not an accident. Like I said, the maps I was going over quickly, overlapping the redlining maps with any of our health outcomes that we have here in the region. It's no wonder that they are not, it's not an accident, I suppose. So let me look at the right, this question is insurance driven, but also more education is needed. Again, education, all these things our solutions tend to go right to behavioral, even if they are massive, right? Like you're saying, you want a mass education or change public education, but they still tend to go down to not blaming the victim, but thinking about how individuals can change racism. And like I said, part of our research is thinking about who makes the decision and whose values matters. But I also want us to think about these systems and structures operating in that way for a reason and by design. I would say would be my first thoughts on that.
Okay. Thank you, Professor.
I would add this particular point. One, from a legal perspective, our insurance used to have a bias towards physical care, not focusing in on mental health. And until the mental health parity law was passed, that was the impetus to start to have a shift. But that shift does not still fully occur actually in the marketplace. And so still there is a bias towards physical health. It is getting better, but it's not where it needs to be. But a benefit of COVID is the forcing of the healthcare industry to use telemedicine. And there is some showing that more people are receiving behavioral health services through telehealth. So I think that we are going to start seeing a difference in those services being provided and used to a broader degree in the population as we move forward. Again, not perfect, but it is a sign of improvement.
Dr. Modlin?
You know, I agree with what's been said. I would just add, you know, one example of a lot of the men that we see coming to our Minority Men's Health Fair. Again, we started in 2003 with 35 patients. Now we have 2,000 per year. Unfortunately, COVID has impacted our ability to do this. A number of those individuals actually have insurance. They have access to care, but they're reluctant. They're distrustful of doctors, hospitals, healthcare systems. And so I think one thing that we have to do is to develop more of these specific programs that are dedicated to serving their special needs. I'm not saying that every minority individual wants to go or needs to go to one of these multicultural minority health centers, but I've seen countless numbers of individuals in the privacy of the exam room tell me, were it not for this type of venue, I would have never come in. We have to make sure that we let them know that this is a safe space for them. We also have to work, and I forgot to mention this, we need to work to promote increased diversity in the healthcare workforce. Only about 4% of US physicians are African American. I think it's about 6% Hispanic Latino physicians. And again, I'm not saying that every person needs a physician that looks like them, but many do. So we have to do whatever it takes to better engage these individuals. We also actually have to empower individuals to ask questions. There was a study by Pfizer Pharmaceuticals or initiative called Ask Me 3. And if you can teach your patient or instruct or encourage them to ask their doctor 3 questions, it will promote improved health outcomes. Doctor, what is my problem? What do I need to do about it and why? That empowers the patient. When the physician, the nurse gets a sense that you're engaged and you want to improve your own healthcare, you're going to get a better response from that healthcare provider. So there are a number of things that we can continue to do. There's a lot more work that needs to be done. I agree with universal healthcare access for everybody also.
I want to ask a question to each of our panelists. This is a question for all 3 of you. I want you to imagine for a moment that you've been invited to a meeting and you walk into that room and you're the only 3 people who've been invited to that meeting. And sitting at the table are Mayor Frank Jackson, County Executive Armin Budish, Governor Mike DeWine, and President-elect Joe Biden. And they ask all 3 of you the following questions. What are the problems and health disparities that I need to deal with? What do I need to do about it and why? In other words, I'm borrowing the question that Dr. Modlin just asked, and basically say these 4 people are looking to only 3 people in the world today for their answers. And that is Professor Walsh, Professor Majette, and Dr. Modlin. The world is in your hands right now. What are you going to say? We'll start with Professor Walsh and then go to Professor Majette and then Dr. Modlin. Nothing like putting you on the spot and telling you that the whole world is watching what you're about to say. Go ahead.
Oh, yes. Well, I'm here to solve all the world's problems right now, so don't worry. No. If I had that audience right now, I think in terms of the immediate issues, especially with COVID, I was thinking about this a lot, and a lot of our research has intentionally looked at people from different, not only racial and ethnic background, education, all the typical variables, but ideologically, we went out of our way to speak to a lot of ideologically conservative people in our sample. And I think part of, the people that you just spoke to there, we have a Republican governor, and thinking about the shared values. So what I would say is what we have as a problem is a lack of understanding of health and our interconnectedness in health, that we are not doing a good job of finding those shared values and using public health messaging that speaks to everyone. Because to me, part of the failure of COVID and mask and distancing is that there's not been we haven't done a good job at thinking about how would conservatives take this message? What's a better way to talk about this in some places and in some instances? But if I had them, I would be thinking about I would be telling them that our major problems are just that disparities exist, that structural racism is at the heart of them, and that absolutely something has to be done about that. What would I do about it? I would, there's so many things that I think, but I always look at education, fixing public education is sort of at the heart of it, because I think economic opportunity is the way to address structural racism. And again, that's not healthcare, right? Like, of course, universal healthcare would be high on the list too, but if I really had to pick, I would look at sort of those I would look at education. And then I would just want us to work better at thinking about how our views and values are shared and how we interconnect, how we see that structural racism affects all of us, not just people of color, and why that matters for health and health for all, because it's bringing the life expectancy down for everyone in our country. We're having worse outcomes for everyone, regardless. So you may think that's not me, it doesn't matter, but it does, it matters for all of us. So that's my spiel.
Thanks. Professor Majette.
So I think the first thing we have to do is we have to make sure that everybody has insurance coverage. We have a fragmented insurance market. We are relying on a private system. We have the Medicare program, we have the Medicaid program, we have the exchanges for individuals and businesses, and then you have people who just have to pay out of pocket. Everybody needs to be covered. I don't care the mechanism that's used to do it, but we need to just get that done. If we get that done, then we can really start to tackle some of the problems that we have in our system. We now, through the ACA, have mechanisms to monitor what's going on with the different populations. And I think that we need to make sure that we are looking at the harms that those populations are suffering and design programs specifically to address that. We've been trying to do all of these things by just having neutral policies. And at the end of the day, that does not erase hundreds of years of adverse effects of having structural racism. And so we need to make sure that we do that as we think about our policies moving forward. I think that those are two key things that we need to do. I will also just echo what Dr. Maudlin said. I wrote a piece about this in 2003. Communities of color suffer from shortages of individual as well as institutional healthcare providers. You need to provide care in areas that is easy for people to access. I mean, just getting there. You shouldn't require people to get on buses and go travel hours to go and receive healthcare. So I think that we need to make sure that we work on that and that we not only get people in the system, but keep them in the system. I was on a panel with some healthcare providers from California looking at the 1619 project, and there was a pediatrician on that panel, and she talked about the fact that people of color academics are leaving. So this is a problem that they are leaving because they do not feel welcome. We have a problem getting them in the pipeline, getting them through the system, and then when they get there, people are exiting. We need to think about how to make the workforce better. That is extremely important. And so I think that those are key things that we can work on. And these are not hard problems to manage for us to have a better healthcare system and healthier people.
Thank you. Dr. Maudlin?
So, I mean, that would be a great group to be able to meet and speak with. I'd love to have that opportunity. I would actually first ask the group to eliminate and take the politics out of this because it crosses all boundaries. These healthcare disparities. It's not just the socially, the lower social economic strata that is afflicted with health disparities. Even affluent individuals of color have higher rates of hypertension, cancers, et cetera. I would also ask them to make it a national priority. Elimination of healthcare disparities. It really should be a national priority, especially given the changing demographics and how it's going to affect the overall health in the nation. And the other thing I would ask them to do is to invest and look at best practices, existing best practices across the country. There are outstanding programs that are in existence that need support, that need additional funding to be able to continue doing their work. You know, research is very important. It's very important that we invest dollars in new research, but it's also very important that we invest and support existing programs that are effective in terms of outreach and engaging, you know, these minority populations.
Thank you, Dr. Let's open it up back to all of you for any questions or comments that you may have. All you have to do is unmute yourself and identify yourself by name and either make your comment or ask your question. And I warn you, if you don't have a question, I have one, and I would not think you'd want to hear me speak again. So who would like to unmute yourself and put yourself out there? I'm going to give you 10 seconds, and then I'm going to fill that awkward silence. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Okay, so here's my question. I teach a course here at the law school. It's an interdisciplinary course called JEDI, Justice, Equity, Diversity, and Inclusion. And a number of my students in that class are on this call today, and they're getting credit for listening to you. You should know that. So imagine today that I'm giving them a final exam tomorrow morning on this particular seminar. And the question on the seminar, what were the major takeaways of each of the panelists at our community conversation today? So my question to each of you is, what do you want my students to write down right now as the major takeaways, the things that you want to leave with them, distilling all of your years of wisdom into just a paragraph or two that they can write down that I'll test them on tomorrow in the final exam. And this time I'm not going to call on you. Whoever wants to go first, second, or third, do whatever you want. Okay, I am going to call on you then. Okay, so Professor Walsh, sorry, I got to go back to you first. What do you want those students to remember that they have to write on the final exam tomorrow?
You have called on me first every time. It's not...
That's because your last name is W, and I always start at the end of the alphabet.
Okay, great. So I suppose there was so much I didn't get to say. It's not enough time, but I think if I wanted them to take away anything, at least from my perspective in the way that I look at racism and health and social determinants of health, it's thinking about the idea that to understand and to tackle these problems, we absolutely have to understand those policy and those law decisions that all of you make and are a part of. But we also have to understand that people are parts of institutions, and that those institutions and policies are designed by people. And we want to understand the way that it affects, we want to understand the way that laws and policies affect people. And so someone like an anthropologist like me trying to understand the way the ACA has had an impact on someone's life, or the way the Cleveland Clinic, Dr. Mondlin, I was thinking about how many interviews I've sat in with people talking about their distrust of the Cleveland Clinic, and how, you know, no matter what I say or what you would say to them, there's so much there. And part of it's misinformation, part of it's just family legacy. But thinking about how we can't tackle these problems unless we really try to understand the way that people live and view health and live and view race in America. And we're specifically for this topic of thinking about structural racism and health. So that would be my takeaway, I think.
Who wants to go next? Professor Majette.
I think takeaway. Okay. I think there are a couple of core problems that communities of color suffer that are important to highlight from an access to care perspective. So I would like them to recognize that people of color suffer from lack of access to insurance. This has been a long-standing problem, and we need to make sure that they have that insurance. And so there are statutes that create that. And so that's important to understand and know. We also want to make sure that when you create those insurance markets, that regulations, that you also make sure in the implementation process that people are educated about those choices and know about those choices. The second piece was what I mentioned before, that is this shortage of healthcare providers. And again, laws govern that. There are laws that govern who gets admitted to medical school, and just the pipeline, college, all of that. So that's important. We need to be thinking about what are our laws doing with respect to getting people into the medical profession, and also in keeping institutions in neighborhoods of color. Title VI initially, before the Supreme Court limited its purpose, used to be used as a tool that blocked hospitals from leaving communities of color. But now that is not a tool. So those neighborhoods don't have access to care. So I think that those are two things that are important to think about with respect to our laws. And also my third point would be to just think about not just the domestic, but also the international laws, that there are treaties that the United States has signed that imposes obligations on them about how they're supposed to be treating people of color. They're legal requirements. Their enforcement part in the international environment is a problem, but they are supposed to at least file the documents, let us know what they're doing, and continue to advance compliance with what those international norms are.
Dr.
So
Mottle.
I would just relate to your students and reinforce the fact that everybody, you don't have to have a nursing degree, a physician's, MD degree, a dental degree to be a healthcare provider. Everybody is a healthcare provider. Everybody can actually play a role in eliminating healthcare disparities. Everybody can disseminate important health, life-saving information, encourage people to go get a health check, get screened. So we're all healthcare providers. You don't have to have a medical degree to be a healthcare provider. I would also say utilize the education that you've been fortunate enough to receive to give back to the community. Figure out a way in which you can give back and serve the community. There are multitudinal ways in which you can do that. The community actually is depending upon you to help empower them, help disseminate important health information, help disseminate the fact that actually healthcare disparities exist. It's striking that a lot of people still don't recognize the fact that these healthcare disparities exist. So you can actually be a major force and focus. And I'll go back to what Dr. King said, of all forms of inequity and injustice in healthcare is the most shocking and the most inhumane. And so if you just keep that in mind and recognize that we're all healthcare providers, we can actually play a major role in eliminating healthcare disparities.
Well, those were terrific takeaways. Before I conclude today's conversation, I want to give our audience one last chance to ask a question or make a comment, and then I'm going to make some quick concluding remarks. But first, I want to give everybody that opportunity. Anybody have anything they want to say? Doesn't have to be a question. It could be a comment. Whenever it is, anybody have anything? Okay. Wait, I think I see somebody. Yes. We have Zakia. Are you comfortable saying this yourself, unmuting yourself?
Yeah, I'm cool.
Okay, go ahead.
Hi. So my question is, currently within healthcare, there is a transition to using telehealth. Do you think this will help curb health disparities? I know that there's other methods within the hospitals that are transitioning online or speaking to clients through the computer or through audio. I mean, through the telephone. Do you think that will possibly help reach out more to minorities?
I think actually there's definitely a beneficial effect. I mentioned some of the social determinants of some people don't have transportation, they live far away from the hospital. And so it actually facilitates people to be able to better interact with their healthcare providers. We at Cleveland Clinic and some other hospitals, we have something called MyChart. Also, it's a two-way communication tool. You can download it and you can enroll at Cleveland Clinic and elsewhere. You can actually just email, your doctor questions. We email back within 24 hours. You can check your blood work, your laboratory results, your x-rays. And so, distance health, virtual health technology actually has definitely benefited many individuals. But we still need to be able to see in many situations, people in person. We need to lay hands on people, do physical examinations. And so it's not going to replace, the individual exam room interaction that we have, but definitely it's definitely a positive. We've already seen a positive effect.
I just want to this particular point though. There also are barriers to using this technology. And so the literature has shown that people of color are not using the technology as much for 3 reasons. First, they don't have access to the technology. That's from probably an economic perspective. Secondly, they don't have access to the internet, again, an economic perspective. And then third, in some communities, especially the elderly, they have technology literacy issues. And you see that more with people of color than other groups. So not discounting what Dr. Maudlin just said, but I just want to highlight that the just accessing the technology is a problem. And I will just add, I mean, I saw that in the literature, but I have a friend who is a cardiologist, and she talked about her practice, and she saw a marked difference with her patients of color being able to use the telemedicine versus her non-persons of color.
Wonderful. Professor Walsh, you said I was calling you first. I'm calling on you last.
Oh, I was just going to say the same thing that Professor Majette said, that we do have to think of digital divide issues when thinking about telehealth, and just whether, you know, just the competency issues that still come with that as well. No matter who, you know, you still have all the issues with competency and inability to convey proper care, whether it's telehealth or in person, right? So just some of those same things will apply, but yeah.
Thank you. Any other questions or comments that anybody has? If not, I'm going to leave you with 6 quotes. So those of you who are my students, if you get these, if you mention these 6 quotes in your final paper and explain each one, you will get an A automatically. So here they are. Here are the 6 quotes. Number 1, and we heard Professor Majette and Dr. Maudlin give this quote, so I'm going to repeat it again. And that is Martin Luther King's quote that of all the forms of inequality, injustice, and health is the most shocking and the most humane. Second quote from MLK that we heard from Dr. Maudlin: our lives begin to end the moment we remain silent about the things that matter. Number 3, another quote from Dr. Maudlin: where you live determines how long you live. And of course, that shouldn't be. Another way of saying it in my speak is where you grow up should not determine where in life you end up. Next, racism is a social determinant of health. We heard Dr. Maudlin say that, and I know all our panelists will agree with that. And then finally, I do want to correct Dr. Maudlin, who's usually right on everything, but he was wrong on one thing. He said that Hillary Clinton said that never let a good crisis go to waste. Like most great quotes, she was quoting Rahm Emanuel, who was quoting Winston Churchill. Winston Churchill said, never let a good crisis go to waste. So let's hope that we do not let this crisis go to waste, not wealth, but to waste, and make sure that we take advantage of the fact that Mayor Jackson, County Executive Armin Budish, Governor Mike DeWine, and President-elect Joe Biden will be depending on these 3 finalists for their state, national, regional, and local healthcare policies. We could do a lot worse if they did depend on them, and I'll do my best to arrange that meeting, Dr. Maudlin.
I appreciate that.
Thank you. Thanks for 3 great panelists. Thanks for tuning in, and we'll have another community conversation coming up soon. Thanks again, everybody.
Okay, thank you.
Okay.
Bye-bye.
Thank you so much.